The most common epilepsy surgery is temporal lobectomy or anterior temporal lobectomy, and that's where most of the research has been done. And so I guess my comments will reflect that. So if we think about anterior temporal lobectomy, the research indicates that the biggest long-term risks relate to memory and, in a selection of patients, language changes. And I emphasise long-term because we know that immediately after the surgery, the dynamic changes taking place in the brain and the recovery process going on, which is understood in the context of neuroplasticity, means that we don't always get a really reliable or accurate picture early post-surgery, and so we need to do assessments longitudinally, and we need to look over the longer term, which might be, at 5 or more years after surgery. I did a review of what literature we currently have, and there are very few studies. In fact, I could only identify 3. So we're talking a very limited literature, and I guess the first point that highlights is the need for us to do more. But what that literature shows is that there are signs of improvement. If we have an intervention that focuses on improving memory, and all 3 studies have focused on memory, that those interventions are effective. Now, we need to keep it in mind that they're not randomised controlled trials, so they're not the top-level evidence that might go with a fully randomised controlled study. However, the signs are promising, and I think what they tell us is that we need to do more, and we need to have more on the different types of approaches that you can take and what are the most effective strategies. So just in relation to that, some of the approaches come under the compensation or compensatory strategies, where we help patients get around memory difficulties through the use of diaries, iPhones, other devices, mnemonic aids, those types of things. But then there is, I think, a very interesting literature that looks more fundamentally at plasticity mechanisms and whether we can retrain the brain after surgery. Really drawing on the brain's capacity to change its plasticity over the lifespan. We know that neuroplasticity is a feature of the brain throughout life now. And so retraining based on that to actually get improvements after surgery. And there's one key study that's shown that certainly has potential too. Yeah. The retraining strategies can be quite varied, but they may involve things like online training exercises, mnemonic strategies that you teach the person to use. And the issue here is regularity or frequency of training, dosage, how much do you need to do and for how long. And they target the function itself. So they target the skill that you're trying to retrain, and then the idea is that you then hopefully can generalise that to daily life and a broader range of settings. Compensatory strategies are really workarounds, and we might all use those to a degree in our own life, right? We're all busy, and so we'll use things to help enhance our memory. We're not actually improving our memory per se when we use those compensatory strategies. We're helping our memory, and that they are traditional things that we would use, like diaries and alert systems and devices that beep and help us organise our life. So I think the literature needs to work out what's the best combination. The research needs to look at what's the ideal set of strategies for a person and make it precision rehab. Who's going to benefit most from retraining versus who's going to benefit from compensation.